Hello friends, today we are going to discuss this study which is published in British Journal of Anesthesia exploring relationship between intraoperative and tidal carbon dioxide levels with postoperative outcomes. There have been few previous observational studies which compared post-intraoperative hypocapnia to postoperative outcomes like mortality and length of stay. However, the relationship between lower and tidal CO2, patient factors, types of surgery and ventilation characteristics have not been explored so far in these studies. So we hypothesized that low end tidal CO2 levels is linked to high rate of postoperative pulmonary complications. We did a post hoc analysis of two randomized controlled trials in which a lung protective ventilation was used and high versus low PEEP was compared in obese patients, which was PROBESE study, and in non-obese patients, which were PROVHILO study. An end-tidal CO2 cutoff of 4.7 kilopascal was used to differentiate between low end-tidal CO2 levels versus normal to high end-tidal CO2 levels. What we found was despite use of lung protective ventilation, which means low tidal volume, one-third of the patient actually had a lower end-tidal CO2 levels. And these patients were older, taller, and had lower BMI. What we also found was these patients were actually ventilated with a higher minute ventilation, which means inadvertent higher respiratory rate because the tidal volume was kept low in both the groups. The primary outcome, which was postoperative pulmonary complications, were more frequent in patients with lower level of end-tidal carbon dioxide levels. There was inverse dose-dependent relationship between end-tidal carbon dioxide and PPCs. The relationship was not affected by PEEP, BMI, or ARISCAT score. And the study concluded that low end-tidal carbon dioxide is associated with higher rate of developing a postoperative pulmonary complication. As this was a post-hoc analysis, we propose future randomized studies or prospective studies to validate our findings, but also to identify an optimum level of intraoperative and tidal CO2 levels. Thank you.